Hello guys, this is Dr.Ajinkya here. Welcome to my channel on YouTube. Today I'll be discussing about CT SCAN PNS, that is how you can actually read a CT SCAN PNS. So this video is basically for those PG students who are in final year appearing for the MUHS theory and the practical exams of E.N.T. So basically the examiner has got 4 spotters for you, one of them being the specimens, surgical instruments, CT scans, MRI scans. It can be of any region, the CT head, CT brain, CT orbit, CT PNS, MRI neck, HRCT temporal bone. So they just might ask you any simple question about the anatomy as a spotter. So I've been there, I've done that. This is all I'm talking about, whatever experience I have in my teaching career. So I hope to share this with you guys. So let's begin. So basically the examiner will hand you a CT scan. You have to identify what type of a CT scan that is. So basically, as you can see over here, this is a coronal view CT scan PNS showing the area of the brain, the orbit, and the sinuses basically. So you can see over here it's a bone scan, so it's a bone window. It's a 1.0 coronal section, so the thickness is 1.0 mm. So you have to start as sir, this is a CT scan coronal view of thickness 1 mm showing the region of the brain and the paranasal sinuses along with the orbit. So that's the first line you're gonna use. Second thing is that the examiner directly will point out to any specific anatomy on the scan itself and will expect you to identify that and give the answer to it. So in the next 5 to 10 minutes, I'll run you guys through the basic anatomy of the CT scan PNS. So listen to me very carefully. So the CT scan is always read. This is a coronal view from the anterior to the posterior aspect. So I'm going to start from the most anterior aspect right here. So as you can see over here, this is the most anterior aspect. This is the scalp skin, you can see, okay? So this is a scalp skin. This is the nasal skin area. So as you go behind, you can see the whitish appearance. That's the frontal bone. So you can see the nasal bone also appearing, the nasal septum. Now this kind of septum is the cartilaginous septum, remember that. So as you keep on going behind, you can see the brain appearing. Okay, now do not confuse this area with the frontal sinus. Now this is having a opaque soft tissue shadow which is grayish, so it has to be the brain, and it is at a higher level. So as you can go behind, you can see these 2 lobes of the frontal lobe appearing. So this cannot be frontal sinus ever. Frontal sinus will be always below that and most anteriorly. You can see this is the frontal sinus, and as you can see, the right frontal sinus is pneumatized and is having air and minimal collection, you can see. But on the left frontal sinus, you can see the entire sinus being opacified with the collection. So you can see that this is a frontal sinus and this was the brain. Do not confuse with each other. Do not interplace these two. The frontal sinus will be always below, the brain is always above. And you can see this long elongated process. That's the frontonasal process of the maxilla. So that's the frontonasal process of the maxilla. That's the perpendicular plate of the ethmoid appearing in the nasal septum now. Now that's the cartilaginous part of the septum. That's the bony part of septum. So you can start start seeing the eye globe appearing over here. So this is a tilted scan because the right side structures are appearing first as compared to the left one. So this patient is having a tilt to the left side. So the right side appears first. So this is the frontal sinus. As you keep on going behind, you can start seeing the front. Now, as long as the floor of the frontal sinus is maintained here, as you can see, the beak is maintained, it's the frontal sinus. As soon as this floor disappears, the frontal recess starts. Now keep that one important point always in your mind. Whenever the floor is not seen, that is the frontal recess area. Whenever the floor is seen, that's the frontal sinus area, and this is the frontal beak which forms the floor and the anterior inferior wall of the frontal sinus. So you have to remember these points. So as you keep on going behind, you can see the frontal sinus being much more prominent right now, and you can see the bilateral frontal recess area having pneumatization as well as collection within. So that is why it is opacified. So that is about the frontal sinus and the frontal recess. You can see the crista galli in the center. The crista galli is an indication that the cribriform plate has started. And always remember that the frontal sinus is always anterior to the cribriform plate, and the cribriform plate is always posterior to the frontal sinus. Always remember that. Okay, they do not intermingle with each other. They are anterior posterior to each other. Okay, so you can see this is the orbit over here. That's the lamina papyracea. That's the lamina papyracea. Now what an examiner can ask, now these are very simple questions. The examiner will not ask these questions for a final year postgraduate student, so he will try to test your knowledge. So what he's going to do is he's going to directly ask you, identify me the nasolacrimal duct. Now where are you going to find the nasolacrimal duct, the NLD? Now, how to localize the NLD? Now, here, as you can see, this is the nasolacrimal duct over here. See, the simple basic funda in the identification of this, the nasolacrimal duct, is that follow the frontonasal process of the maxilla. As you can see over here, that's the frontonasal process of the maxilla. Keep on following that, keep on following that. And on the lateral aspect of the frontonasal process of maxilla, you can start seeing an opacification in a tunnel shape, and that's the origin of the nasolacrimal duct and the lacrimal sac. So basically this is a lacrimal sac you can see over here, and below you will see the nasolacrimal duct opening up into the inferior meatus. So as you keep on going up, just keep on following my cursor. You can see actually the sac being opened in the inferior meatus. So that's the first question the examiner can ask you, localize the nasolacrimal duct. So the nasolacrimal duct is always between the frontonasal process of the maxilla and the orbit. So you can see this is in between these two. And as you can follow the scan, as you keep on following the scan, you can see this is the frontonasal process disappearing, and the nasolacrimal duct opening up into the the inferior meatus. I'll show it to you one more time. That's the lacrimal sac. That's the nasolacrimal duct. You can see it's coming down, and there it goes in the inferior meatus. So that is how you identify the nasolacrimal duct. Now, what is the next question that the examiner can ask is that they are not going to ask any simple questions, remember that. So they're going to ask only confusing questions. The first one was the NLD. The second one will be somewhere around the anterior ethmoidal artery, for say. So the examiner will ask you, identify me the anterior ethmoidal artery. Now, you just all have to remember there are 3 points for where you can identify the anterior ethmoidal artery. Now, as I keep on going posteriorly, now here is the region of the anterior ethmoidal artery. As you can clearly see, there's a narrow beaking of the medial wall of the orbit happening over here. Now, if you're watching a CT scan, now this side is very much clear. On the left side, you can see this beaking over here. Now, whenever you're seeing a CT scan and you can see this nipple shape, okay, now we call this as nipple shape. So this nipple is also called as the Kennedy nipple sign. So if the examiner asks you also a question, what is the Kennedy nipple sign, and show me on the CT scan. So you hold the CT scan and you show that guy that, dude, this is the anterior ethmoidal artery. Okay, so how did you identify the artery? Is basically you just have to follow the lamina papyracea. That's the medial wall of the orbit. And the moment you see a beaking appearing like this, always remember this beaking will happen between the medial rectus muscle and the superior oblique muscle. Okay, so this is, you can see the soft tissue shadow over here, that's the medial rectus, and just above you can see a small shadow that is the superior oblique muscle. So always in between these two. So whenever these two muscles come very close to each other, this narrowing or beaking occurs always. So you can clearly see here the beaking appearing. That's the anterior ethmoidal artery. So I hope this becomes very easy for you. Now, there's one more confusion. If the examiner may also ask you, okay, okay, now you found the anterior ethmoidal artery. Now find me the posterior ethmoidal artery. Now, trust me, guys, posterior ethmoidal artery is normally not visible. If you look very carefully, you can definitely see the posterior ethmoidal artery. Now see, this skull base has a slant, right? It has an angle to the cribriform plate. So always it is the anterior ethmoidal cavity or the anterior ethmoidal skull base, because the posterior ethmoidal skull base is flat, like horizontal, and the anterior ethmoidal skull base is like having an oblique angle to the cribriform plate. So whenever you see the skull base like this having a acute, you can say a slope, that's the anterior ethmoidal skull base. So always a beaking will be of the anterior ethmoidal artery. But if you keep on going behind, look very carefully. I'll zoom in for you guys. So when you look very carefully, you can see another beaking happening here, right? You can see this slight faint beaking happening here, very difficult to identify though. And you can see this is the posterior ethmoidal skull base, which is almost flat, like horizontal, as compared to the anterior, which had a slant. So this area is the area of the posterior ethmoidal artery on both sides. So that is one more question you can just slam on the examiner's face. So that's saying that this is the posterior ethmoidal artery. So we covered NLD, we covered the anterior and the posterior ethmoidal artery. Now the examiner may ask you, if you keep on going behind, if he wants to ask you a difficult question, just to confuse you and scare you, so that you guys can start tremors. So to prevent that, I'll help you over here. So the next question, just let me think over it. Yeah. So he may ask you a question, what is the rostrum, or you can say localize me the rostrum of sphenoid. Or you can ask me, or you can ask you guys, where does the sphenoid actually start, and how you can identify that the sphenoid sinus has started. So always remember that you should know what the pterion is, right? The pterion is nothing but the frontal bone over here, this point over here, this point over here, that's the pterion. And you can see from this pterion to this pterion, this skull base is completely intact. Okay, it's a complete continuous horizontal line. As the moment you go behind, keep on going behind, there's a break over here. You can see a clear break over here. See, so that is no longer the frontal bone, that is the lesser wing of sphenoid now. Now this is a sphenoid bone, and this is the lesser wing of sphenoid. I'll repeat, this is the lesser wing of sphenoid now. Okay, so the moment the break starts right here, that is the posterior most aspect of the posterior ethmoids. And if you keep on going behind, you can see this is a posterior most aspect. You can see here the superior turbinate, the middle turbinate, the inferior turbinate very clearly. And as you keep on going behind, you can actually start seeing the sphenoid sinus very clearly over here. So this patient has bilateral sphenoid sinusitis with a lot of air gas shadow over here. So it could be a fungal sinusitis, it could be a secondary infection in the sinus itself. So that was nothing but the lesser wing of sphenoid. Now what you see like this is the anterior glenoid process. Now this is the anterior glenoid process, that's the sphenoid. And where the rostrum of sphenoid was is right exactly before the origin of the sphenoid. So as you can see over here, if a question is asked about the rostrum of sphenoid, you got to follow the nasal septum, the bony septum. You can see this is a bony septum, which is very thinned out. So if you keep on following it posteriorly and this starts to fade off, you can start seeing this to become much more thicker, right? So this becomes thick as compared to the nasal septum, which was thin. So this thickening of the posterior aspect of the nasal septum is nothing but the rostrum of sphenoid. So that's the rostrum of sphenoid. So another question set. So he may ask you, localize me the optic artery, the optic nerve and the carotid artery. So you guys are going to be like, where is the carotid artery and where is the optic nerve? So do not worry, just keep on following the lesser wing until a point you start seeing something like this, two horn-like structures, right? These two horn-like structures are nothing but the anterior glenoid process, right? So the anterior glenoid process is a very important landmark for the optic nerve and the carotid artery. So you can see on the medial aspect, you can see a cup shape. I'll just zoom in this for you guys. You can see this C-shaped, or you can say a cup-shaped depression over here on the medial aspect of the anterior glenoid process. Yep, that's nothing but the optic nerve. Now you cannot see everything on the CT scan is same. It's homogeneous, grand sand-like, it's a grain of sand-like structure. You cannot differentiate any structure out here. because this is a bone window, so you cannot even see the soft tissue properly. So if you're given such a scan, how you can identify the optic nerve is just follow this anterior glenoid process. Wherever you see this cup-shaped depression right here, that is nothing but the optic nerve itself. You can see it very clearly over here. So again here a question may arise, say the examiner may ask you guys to make it more tougher for you guys, to make it a challenge for you. He may ask you what is the grading system or the classification system for the optic nerve relationship with the sphenoid sinus wall. Now your answer will be, obviously it will be Delano classification. Now the spelling is Delano, D-E-L-A-N-O, Delano classification. So there are 4 grades in Delano classification. Grade 1 is that the sphenoid sinus does not have any bony indentation of the optic nerve. Second is that slight indentation of the optic nerve you can see on the posterior lateral wall on its superior lateral aspect. Third is that the optic nerve is actually passing through and through the sphenoid sinus like a separate bony canal. So you can actually see the optic nerve as a canal, separate canal within the sphenoid sinus. And what is grade 4? Grade 4 is the same thing as of grade 3, but that is extending up to the posterior ethmoids as well. So that is the Delano classification for you guys. So one more Viva question from the examiner. Similarly, you can see on the lateral aspect of the anterior glenoid process. Now, this is the anterior glenoid process over here. This was the optic nerve. Similarly, this you can see a huge C-shaped concave depression over here. You can see this. That is nothing but the carotid artery, the internal carotid artery indentation. So this is the optic nerve, this is the ICA, this is the sphenoid sinus. So that's it. You can show the examiner the carotid artery. Now, the next question may arise is that the examiner may ask you, show me the canals. Show me the canals or the foramens in the CT scan. He may ask you to show you the Vidian canal, the foramen rotundum. So as you approach the sphenoid sinus like this, you see the anterior glenoid process, you see the optic nerve, you see the carotid, sphenoid, the rostrum, the nasopharynx. Now this is a nasopharynx over here, that's the choana of right and the left side. You can see something like this, 2 holes, okay, 2 holes over here. And this is nothing but the pterygoid wedge, that's the pterygoid body. You can see here alongside the choana, you can see the medial pterygoid plate, you can see the lateral pterygoid plate. Okay, that's the medial pterygoid, lateral pterygoid. This entire complex is of the sphenoid bone. So that's the choana, and you know that choana is formed by the lateral margin is formed by the medial pterygoid plate. So you have to remember all these basics. Only then you can be able to have a rapid fire round with the examiner and you can pass in that. So this 2 holes you can see over here, always remember the rule. Vidian is median, okay? It's very easy to remember. I'll repeat again, always remember the rule. Vidian is median, okay? That rhymes a lot, right? So whatever it is medial, it is Vidian, right? And whatever is lateral and superior is always the V2. That is nothing but the foramen rotundum. And what is V2? It's the maxillary nerve. So this is a foramen rotundum and it contains the maxillary nerve. This is a foramen rotundum and contains the maxillary nerve. This is a Vidian canal, the huge one. This is a Vidian canal which contains the Vidian nerve actually. Okay, so this is how you can give the answer yet again to the examiner. Now, I was personally asked this question when I was a final year resident. Now, I'm a skull base surgeon right now, but I was a final year resident sometime back. So this question was asked to me in the Viva practical exam in my examination. So he asked me where is the foramen rotundum and the Vidian canal. So here it is. That's the Vidian canal foramen, and that's the foramen rotundum. That's the FR, V2 maxillary nerve. So moving on to the next question, the next question. Okay, that's the end of it. Now, he may ask you a question showing locate the orbital apex. So it's very simple, guys. You just have to, follow the orbit. Just keep on following. This is the orbit over here. Just keep on following the orbit posteriorly to its limit. Behind, you can see the end of it. Now, this is the orbital apex when it corresponds to the sphenoid sinus. Okay, so when it corresponds to the sphenoid sinus, just at the anterior aspect, most anterior aspect of the sphenoid lateral wall, you can see the orbital apex. Okay, so you can see that's the sphenoid, and you don't know the most anterior aspect of the lateral wall, you can see over here, somewhere here is the orbital apex. Now they may ask you to localize cavernous sinus on a CT scan. Now it's very tough to localize a cavernous sinus on the CT scan, but still you gotta locate that, right? So the investigation of choice for cavernous sinus lesion is always, remember, post-contrast MRI scan. Okay, it may be a T1 it should be a T2, or it may be a T1 post-contrast cause it flares up, so you can easily see the venous channels in the cavernous sinus. Okay, so always remember that point. So if on a CT scan they ask you to localize the cavernous sinus, you just have to follow the sphenoid sinus. Now what is sphenoid sinus? Now lateral wall of sphenoid sinus is nothing but the cavernous sinus. Okay, so this is the cavernous sinus over here somewhere. So if you remove the lateral wall of the sphenoid sinus, you're gonna land up in the cavernous sinus. And you know that in the cavernous sinus we have the carotid artery, which is right here, as I mentioned some time back, and just lateral to the carotid artery will be the abducens nerve, and this will be somewhere the lateral wall of the cavernous sinus, having the third, the fourth, the fifth one, and the fifth two. See how things fall into a simple place. This was V2, right? Now V2, always remember guys, listen very carefully please, V2 is the floor of the cavernous sinus. Okay, so V2 marks the inferior limit of the cavernous sinus. So as you can see over here, this is the V2, that's the foramen rotundum. So this will be the floor of the cavernous sinus laterally. So here somewhere will be the third, then the fourth, the V1 and the V2 over here, the abducens over here, and the carotid over here from medial to lateral aspect. Okay, so this is the cavernous sinus. So be confident and give the answer. That's the cavernous sinus or right over there. And the final question they may ask you is that somewhere around here, they may ask you where is the inferior orbital fissure, where is the superior orbital fissure, where is the foramen of sphenopalatine foramen. So at times it may seem very difficult, but it's very easy, trust me. So you just have to follow the maxillary sinus for that. So if the question is locate the sphenopalatine foramen, okay, so you just have to do one thing. You just have to follow the maxillary sinus, keep on following it, go posteriorly. You will start seeing an inferior opening in the orbit, and that opening is called as the inferior orbital fissure. You can see the same thing over here, that's the inferior orbital fissure. Now once you start seeing the inferior orbital fissure, always remember that the sphenopalatine foramen is right below it. So I'll show you the foramen as well. Just keep a look at this area. This is the inferior orbital foramen. Keep going behind. This is the entire intraorbital foramen. That's the infraorbital fissure, or you can say the foramen. Mostly it's called as the IOF, the infraorbital fissure actually. So you just keep on following it, and there you see the bony opening. See, all this time there was a vertical bone. This is nothing but the perpendicular plate of the palatine bone. So at particular point, if you start going posteriorly along the inferior orbital fissure, you will start seeing a gap in the bone over here. Look very carefully. Okay, you can see a gap in the bone over here. There it is. You can see the gap over here. So I'll show you on this side as well. So just keep on following the maxilla, posterior wall of the maxilla, and the perpendicular plate of the palatine. This is the inferior orbital fissure. Just pay close attention to the bony gap over there. There it is. See, there's a bony clear cut, there's a bony gap over there, and that bony gap is nothing but the sphenopalatine foramen, from which the sphenopalatine artery comes. Now remember that the sphenopalatine artery in most of the cases, say around above 80%, divides into 3 branches before the exit of the foramen. So when it is not even at the foramen, just before the foramen, it divides into 3 branches. One goes to the posterior lateral aspect to form the posterior septal artery. The other two goes to supply the inferior turbinate and the middle turbinate. Okay. So this is the inferior orbital fissure over here. That's the sphenopalatine foramen over here. So I think this is a very basic anatomy examiner can ask you. Now, if the examiner asks you certain questions beyond this range, I think they will be very easy for you guys to identify, because I have covered the most difficult questions the examiner may ask you, to confuse you guys. Because normally the PG students do not read at this level because they have to read a lot of it. So I hope you watch this video and you find this video very helpful. And if you guys are preparing for skull base notes, I have in my description panel mentioned various links to various skull base books, so you can go have a look at it. So I think this is all for the CT scan spotters in the exam. And in upcoming videos, I'll be uploading the videos about the specimens in the PG exams, the instruments, the E.N.T instruments, the surgical instruments in detail. The audiogram I'll be explaining in detail. Those who are interested, they can watch. So I'll be covering basically all the lectures of the examination point of view. So thank you guys. Keep subscribing, keep liking, and whatever doubts you have, you feel free to comment in the section below. I will definitely give reply to all of you guys. Okay, see you then. Take care. Thank you.